So it's my great pleasure and honor to introduce our next speaker, who will be speaking to us on the topic is Finding Flow, Functional Aesthetic Treatment Strategies. And so he's a good friend, a good colleague, Dr. Pio Modi. I think we've known each other for several years now. He's a teaching assistant at the Dawson Academy and founder of former Dawson Study Club, which is the Toronto chapter. And for those of you who don't know Dawson, one of the leading organizations as far as occlusion and management of occlusion. So Dr. Modi's created multiple video modules for training for both Dawson Academy and the American Academy of Cosmetic Dentistry, and he does some phenomenal work when it comes to cosmetic dentistry and managing even these full mouth cases. So I'm excited to welcome into the Dentistry Academy lineup and looking forward to his presentation. So Pio, it's all yours, buddy.
Thank you, Azim. I really appreciate those kind words. I mean, as you guys know, Azim's a phenomenal dentist and runs an amazing implant study club. And I'm just going to bring up my screen here and we'll get started. All right. So, and I want to thank you guys. Hisham, it's such an awesome what you guys are doing. Hisham, Mark, for saving me last week. I was on last week and these guys, my internet went down, my router went down. So I've now learned to always plug in to your Ethernet cable when you're doing a presentation. But the guys are Jeff last week, Mian, and all you guys at Dentistry Academy. Thank you. It was a huge honor. And John, your presentation was great, and I'm hoping to continue from what you did. So my presentation today is called Finding Flow. With the goal, this is something I'm very passionate about, and the goal is to find and to give you guys functional aesthetic treatment strategies to help with your cosmetic cases. The journey today, how we're going to be approaching this, what we're going to be looking at is we're going to look at three sections. First section is the planning. This is where it all starts. Creating that plan that you know is going to work for the patient, that's going to give you predictable restorations. Building in progress, staging your treatment and getting everything ready for those final porcelain restorations. And lastly, stable glass, restorations that are going to last. So obviously, all of you guys, it's stressful times. It's a COVID shutdown. We don't know when we're going to be opening up. It's incredibly stressful. This is me with my family. For those of you who saw last week, it's my three sons, my wife, and our dog. There's been a lot of homeschooling, which is it's fun. They've actually been great. They've actually been really good boys. And this is my youngest guy auditioning for the next Scorsese movie. John was talking about singing Let It Go. He's obsessed with Frozen. And if I hear Let It Go one more time, I might have to jump through a window because we hear it all the time. So the plan. So now we're going to get into the planning for these cases. And when you're thinking about cosmetic dentistry or anything involving anterior teeth, your full mouth rehab, to your implant dentures, we always look at the smile. I mean, this is where we want to start and make sense. I mean, obviously your treatment planning has to involve the teeth and looking at the teeth in space and designing that smile. But a big part of what I want to present to you and what's a big part of the Academy and with the Dawson Academy is all of our treatment planning starts here at the TMJs, okay? Looking at the TMJs and doing a proper functional assessment before we start doing the cosmetic treatment. And when we're looking at these cases, there are some functional goals that I want to share with you that I feel are very helpful. First thing is your joint position. In the joint position where we start at, now this is when patients have signs of occlusal instability. So signs of occlusal instability are patients who are wearing their teeth. Physiologic wear is about 0.01 millimeters. Anything beyond that, 0.01 millimeters per year, anything beyond that is considered they're wearing their teeth. Teeth that are mobile from primary occlusal trauma, or teeth that are migrating or shifting, okay, from occlusal forces. This is our starting point. This is centric relation. What is centric relation? This definition's been around for many years, and what this definition is it's a jaw-to-jaw relationship, irrespective of tooth position or vertical dimension. When you're looking at the proper condyle disc assemblies, with that jaw, that condyle being seated right up in the glenoid fossa, right up against the distal part of that eminence. It's the most superior position of the condyle. Any position that's not in centric relation is a downward position from CR. And what is our goal? Our goal, one of our functional goals, a big goal, is that when we're establishing someone's bite, we want them to have one bite with that jaw in CR. So basically, we want CR, centric relation, to equal maximal intercuspation, MI. Why is that? When the jaw is fully seated up in CR, all your elevator muscles that we know, your masseters, your medial pterygoids, part of your temporalis, when they're clenching, the positioner muscles, which is mainly your inferior belly of your lateral pterygoid and the anterior part of your temporalis, they can release, which is what that blue is. So basically, it's coordinated muscle function. So when you're closing, your jaw is seating your socket with your positioner muscles not trying to fight it and keeping it in a downward position. What's the second functional goal we look at? When we're looking at establishing anterior guidance, what we want is we want the anterior guidance to be in harmony with the envelope of function. So anterior guidance is that inside-out movement of your teeth. Okay, so in any excursive movement, it's that inside-out movement. And the envelope function is that chewing cycle, which is an outside-in. Okay, and what we want is we want there to be harmony with no signs of wear or mobility or migration of teeth. This is a photo of a patient I'll be discussing throughout this webinar. And you can see here, she's a young girl. She's a nurse. She's one of our frontline workers. She's an amazing, amazing patient. And she's in her 20s. And she's already got fairly advanced wear on her canines, wear on her laterals. She has an enlarged diastema where the space is widening. I mean, she does have an enlarged frenum, but that space is widening also because of forces too. Then this concept of envelope of function, centric relation, a lot of these occlusal concepts can be found in Pete Dawson, who was a founder of the Dawson Academy, his book, which is an incredible textbook. It's so important for foundational knowledge on this. It's called Functional Inclusion from TMJ to Smile Design, something I'd highly recommend you guys looking into. The third thing we're looking at, the third functional goal we're looking at, is we want non-interfering posterior teeth. So the back teeth don't interfere when you're closing into centric relation, and they don't interfere when you grind left or right or forward. Okay, so there's been many studies that have looked at this. The studies, the most common one, I mean, there's been many studies over these years. The landmark study was one that was done by Williamson and Lundquist. It was in 1983, where they looked at the electromyographic activity of muscles when anterior guidance was established, and it significantly drops when you do have this type of occlusal scheme. So what's the occlusal scheme we're looking at? We're looking at dots in the back and lines in the front. So we want centric stops on all the teeth on flat surfaces. So your cusp tips, your marginal ridges, your fossa dips. And then when the patient is grinding in any movement, those red lines are your excursive movements, and that's only on the anterior teeth. So now we have some functional goals that we can work with. The functional rules are centric relation is equal to maximal intercuspation. We have your anterior guidance that is in harmony with the envelope of function. And we have non-interfering posterior teeth. So this is the patient that I was talking to you about. Again, an amazing patient. She was referred to me from an orthodontist. She has a crown on 2-1. For anybody, any Americans who may be on this, that's tooth number 9. And these are the photos we started taking for her, okay? And these are her main concerns. Her main concern is that to close the gaps on her front teeth. This is why she went to the orthodontist first, and he referred her to me because he thought it would be better handled with cosmetic dentistry. She notices that she clenches at night, so she does have some headaches and issues that way. And she also feels like her gaps are widening. So now we're going to get into the planning. And the first step with your planning is your 2-dimensional planning, where you're looking at, you're doing a very detailed exam and looking at photos. The photos we take a series of 21 photos, and we'll analyze those later. But everything with our 2D planning starts with a very thorough, thorough new patient exam. The exams that we all do. The big things that we're doing in addition to, exams that, we generally do are we're looking at the functional side. We're looking at the joints, the muscles from palpation. We're load testing the joints. We're looking at range of motion. Obviously, we're looking at the occlusion. We do a sleep assessment too. And we want to get a complete picture. And this slide here is just showing you a summary of what we found from her exam. Anything yellow is things to be aware of, things red or more of concern, green, everything's good. So with her exam, after we did the exam for her, these are the things that stood out. Like she reported, she clenches and grinds her teeth. She has clicks in both of her TMJs, and these clicks were happening on translation. So when we're checking patients when they're opening and we're checking their joints for clicks, we're checking in rotation, which you just basically have the patient keep the tip of their tongue to the roof of the mouth and open. So that just prevents them from translating. And then we check them in full translation. And these clicks are happening in translation. So these are lateral pole clicks where the disc is coming off the lateral poles of the condyle, which can be a concern. And the last thing, she has exposed dentin. For a girl this young to have exposed dentin is definitely a concern. Here was a good thing with her exam. When we palpated all her jaw muscles, amazingly, there was no tenderness in any of her muscles, which is great. And the other thing, when we load tested her joints, where we do bimanual manipulation, it's very gentle. It's one of our techniques to position somebody in CR. When we load tested her joints, there was no tension or tenderness in either of her joints, which is great, which lets us know that we can work with CR in her case. So now we're getting to something more fun. We're going to look at the photos. Okay, so again, we take a series of 21 photos. It's plugged into this software. It's called the Dawson Diagnostic Wizard, and it really helps us to break down, not only the functional side, but the aesthetic side with our smile design. So now we're looking at her lower teeth. We look at the lower incisal plane, and we look at the posterior occlusal planes too. And a couple things stands out for her. You can see her second molars are very tipped down, okay? And she also has her wisdom teeth too, which are even more tipped down. And without even looking at a set of models or looking at her grinding her teeth, you can tell these are going to cause major posterior interferences. They're going to be banging on her upper teeth in protrusion and in excursions. The other thing that's not ideal is that she has a concave incisal plane. Ideally, you want your lower incisal plane, your lower anterior plane to just be slightly above your posterior occlusal plane. So ideally, you want to flatten, like not a deep curvus B in your posterior plane and a slight rise in your anterior plane. The reason being is then you're going to get that anterior coupling, so you can have those centric stops in those anterior teeth. So she's in this situation, she has a steep posterior occlusal plane and the concave incisal plane, which is not ideal. Now we're looking at our buccal corridor. Again, this is part of the smile design. You want the teeth to fill that smile design. Another great resource for your cosmetic treatment and training is the AACD, the American Academy of Cosmetic Dentistry. I've been a member since 2012, and they also help to zone you in with your smile design. So here, her smile is basically from second premolar, 1.5 to 2.5. American numbers is 4 to 13. And she has buccal gaps present on both sides, which we ideally would like to fill. This is her lips at rest photo. And well, actually, this is looking at her smile photo from her lips at rest to her full smile. And we're looking to see how much lip movement is happening. Does she have hypermobile lips? Okay, so average lip movement is about 8 millimeters. Anything beyond that, where you're showing the gums and showing that gummy smile, it becomes a major concern, especially when you're looking at the gingiva, which is the framework for the art. And for her, she's a borderline high smile line. One thing to caution you, if you have a patient who has borderline high smile line, these patients, when they're actually happy with their smile, they actually might smile even higher, just to be aware of that, okay? Now we're looking at her gingival symmetry. Okay, we're looking to see, we want everything. So basically with gingival symmetry, we want the canines and centrals to basically be on the same level. Laterals is okay if they're slightly incisal, the gingiva, but they can also be that same level. You can see there's a slight discrepancy between the 1-1 and 2-1, the 8 and 9. I mean, the 2-1 gingiva is slightly incisal to the 1-1, but in my opinion, it was very minor. This is her lips at rest photo. Okay, so there was a study done in 1978 by Vig and Brundle. It was called the kinetics of the anterior tooth display. And they were looking to see how much tooth is shown based on different ages. So age 30, they said the average amount of upper teeth that were shown is about 3 millimeters. Age 70, generally you don't show anything. You're just showing your lower incisors. So, again, the reason being is all your facial structures, sadly, as we get older, everything drops, then you show less of your teeth. So for my younger patients, I'm shooting for about 3 to 4 millimeters. Patients who are older, I still want there to be some teeth showing at lips at rest, so about 2 to 3 millimeters. She was just under 3 millimeters, so this indicated to me that we can lengthen her teeth. These are the horizontal slides where we're looking at the tip down shot, which I love, and the horizontal position and profile shot. One of the things you can see here is that when you're looking at this tip down shot, the photos on the left are what ideal is. You can see with hers, you can barely see the laterals and the canines. So they're lingually tipped. So they're actually kind of restricted back. So it creates this restricted envelope of function, which obviously creates a disharmony with the anterior guidance. And no surprise, this is where most of the wear is happening, is on our laterals and our canines. So now we're looking into golden proportions. Golden proportions is a good guideline of how you want to set the widths of your centrals, your laterals, and your canines. You can see here, with her golden proportions, she's pretty close. And actually, it works in our favor because her laterals and her canines are at good width, and it's just the centrals have to be widened. Perfect. So we just close up that diastema, and this tells me that, if we close up that diastema, her teeth aren't going to look abnormally wide with those two centrals. So now this is the fun part. We're taking all that data from those photos, and now we're actually doing the smile design by the numbers. Okay, so we're looking at how we're going to plan to lengthen these teeth. Okay, so where we're going to lengthen these teeth, not only lengthening them, but from the gingival standpoint, are we going to do aesthetic crown lengthening? Are we going to do any grafting? So I plug in all these numbers based on all that previous data, plus this slide helps me determine the width to length ratio. So ideally for your central incisors, you want your width to length ratio to be about 75%. It can go up to 85% as we get older based on wear, but 75 to 80, 85% is the range. And then I plug in these numbers. And then this slide, so the lab I work with, Burlington Dental Studios, they get access to the slides, they get access to this, and then they know where they're gonna wax up these teeth. And then in the software, it gets populated into this imaging, so you actually get to see, where the teeth are going to be, which also helps the lab when they're doing the diagnostic wax up. I mean, there's many softwares that can do this. A very popular one, I was talking to Hisham about it, is the DSD by Coachman. It was also great. And these are just ways to just give your patients an idea of where this case is going to go. So now, once we've got that 2D planning, the next step is the actual 3D planning. Okay, so where it all starts is getting a properly set of mounted models in Centric Relation. Okay, so this was a case that we did where I have the lab mount my models. I sent them a Facebook transfer, and then I sent them a CR record. So what we did with this case is we used a looser jig in the front. I'll talk about it a little bit later. But the looser jig, we reline it with a green compound wax. We fit on the front teeth, and it acts like an anterior deprogrammer. Okay, so it's basically, I mean, so many of these academies have their own version of deprogrammer, but looser jig predates all that. And it's a great way to position somebody in CR because it's an unrestrained position. They're basically positioning themselves. And then we use Delar wax, D-E-L-A-R. There's also Denar wax, D-E-N-A-R wax, to get that record. This is actually a case where I had to have the lab remount the models because ideally those teeth should fit perfectly into those indentations. And you can see it's slightly off. So I had the lab remount this so that the teeth are fitting that record perfectly. And then this is my setup for when I'm doing my workup in these cases. I like to do a treatment planning wax up. This is what we teach, because I want to start planning this case and I want to start working through it so I know where this case is going to go before I send it to the lab. So where the sequence goes, what we like to do, what I like to do first is I like to establish, what we teach is to establish that lower incisal plane first. Get those lower incisors where you want it to be. Then your uppers, generally, you can do all of the upper anteriors. Generally, I like to do the centrals only. I know my waxing, I feel I'm decent with it, but I know my limitations. So I'm doing this from a treatment planning standpoint. So I wax in the centrals only on the upper. And then, so once we have where we know where our lower incisal edges and our upper incisal edges, then we work through the occlusion, determine where we're going to set our vertical and how we're going to equilibrate the case. So these are her models. Okay, so this is the articulator I use is an Artex articulator. It's a fantastic articulator. I love it. Most people at Dawson use the Dinar articulator from Whipmix, which is also a fantastic articulator, works great. They all work well. I mean, there's so many out there, Sam, Stratus, Panadent. I mean, there's so many. As long as it's a semi-adjustable articulator, any articulator can work. Key is when you're looking at your articulator, this video I'm going to show you, I mean, the upper member is what moves, but obviously we know your mandible is what's moving. Okay, so you actually want to look at the mandible. And what we're looking here, we're going to look at her protrusive guidance on her left side and her working guidance. So when she's grinding to her left side, is her separation of the back teeth. But sometimes you can get the sense that there's false guidance when you see separation of the back teeth, and I'll explain. So as you can see, this is the video, and you can see her wisdom teeth, when the protrusion, there's severe posterior interferences. But if she goes in that excursive movement to that left side, there's separation there. But what I want to show you in the next one, that this is false guidance, okay? So again, we're going to look at the protrusion here. You can see really banging on those wisdom teeth there. Looks like there's separation of the back teeth, but when you go on the other side, the balancing side, there's actually very heavy balancing interferences off those second molars in the wisdom teeth. So what's happening is it looks like she's discluding her posterior teeth, so there's non-interfering posterior teeth, but that's false because it's actually being discluded by the opposite balancing contacts, which is really detrimental because it can cause a lot of hyperactivity in those muscles. So balancing interferences are something we definitely do not want. So all of this, I sit down with the patient, I sit down with my analysis, I work through all those slides I was showing you, and I show them my mounted models. I like to have a consult with them before we go to the final wax up, because I just want to know where they want to go. What I proposed to her was building up that lower incisal plane with porcelain veneers. A lot of times I'll do resin, but if it's a long buildup, I don't trust that my resin is going to hold up over time. So I want to do something that's going to last. So I recommend lower porcelain veneers. I recommended upper veneers with replacing the crown 2-1 from 1.5 to 2.5. I recommended doing a frenectomy between 1.1 and 2.1 to reduce that biologic force that was, potentiating causing that diastema, and along with extracting your wisdom teeth, which are non-functioning, doing that surgery all at once. And then from the functional standpoint, doing equilibration and night guard. So she's a young girl. She was paying for this all herself. What she agreed to was the following. She was in agreement with the surgical side, doing that frenectomy and extracting the wisdom teeth. Amazingly, she wanted to do it without any sedation. We do IV sedation for most of our cases, but she didn't want any. She's tough as nails. The only compromise what she didn't want to do is she didn't want to build up that lower incisal anterior plane with veneer. She was willing to accept that compromise and not have those centric stops, especially with those incisors. And she only wanted to go from 1.4 to 2.4. She was willing to not do veneers from 1.5 to 2.5, which we were totally fine with. And she also was in agreement to do the bite balancing, the occlusal equilibration, and then a night guard. Anybody with any sort of functional wear, I always like to recommend a night guard to complete the treatment, because there's a nice insurance policy, because if they have that parafunctional grinding, even if the bite's perfected, over time they can damage these porcelain restorations. So this is her before mounted, and this is her waxing up only to 1.4 to 2.4. Again, I want to do that consult first before I do that final wax up. So now we're in that in-between phase, the phase where we're setting everything up for the final restorations. And this is a building in progress, and I love doing the workup side of this. Now we've done the planning, we got a plan, now we can move. So with her surgery, what we did is we did that frenectomy, we took out the wisdom teeth, same appointment. Okay, and this is her at the time of the surgery after we did the frenectomy, and this is her a month later, already healing great. Based on the healing, how it was going, we're ready to go and prep this case, after, well, I like to wait 3 months after I do any sort of surgery in the front. Now, what I like to refer to when I'm doing these cases, I love to do my own surgery, like Azim, I love to do my own implants. And I always refer to surgery as a rate limiting step with all this. It's going to cause a delay between when you do that surgery to the final restorations, whether, if your implants are immediately loading or not. I mean, there's always going to be a delay until you get to that final point. So I like to call this a rate limiting step, because this is a step I want to get out of the way right off the hop. Some people like to provisionalize and prep their teeth in conjunction with the surgery, especially if you're doing, like, say, an aesthetic crown lengthening. I like to wait personally. I want to know where that gingiva is going to heal before I start prepping. And there was an article that was written by Gingival and his colleagues in 2008, looking at causes of diastema and treatment options, which is referenced below. So now we have our provisional matrix. Okay, so this was made by the lab. I love this design. Okay, it's made off the diagnostic wax up. So the way they design it, they do a blue putty, okay, off the wax up, and then they hollow it out, and then they reline it with a orange light body. And then they create notches along the labial to allow that provisional material to flow out. And it's a great way, it works amazingly well. Often in these cases, you may have to re-provisionalize, and this is a very sturdy way to create a matrix off of that. So now what we're doing now, what we've done for this patient, we've done a mock-up off of her diagnostic wax-up on her teeth. Okay, so this mock-up, it serves three purposes. One, when you do that mock-up, when you're at that prep appointment, so this is at her prep appointment, you do that mock-up, you have her look at it, make sure she's happy with it. Some people like to do videos. I know Jeff was talking about that last week, which is a great idea, to do a video with that mock-up so they can see what it looks like. Okay, so the mock-up serves one purpose. That's one of the reasons I use it, is to let them look at it and make sure they're happy with it. Number two, I start doing my balancing, my equilibration when the mock-up's in place. So I start working out and balancing their bite with the mock-up in place. And then the third reason I like to do this is from a prep standpoint, okay? Because when you have that mock-up on your teeth, you can now really, really conservatively prep these teeth, which is so crucial when you're looking at doing veneers, okay? I like, for, most labs who really focus on the cosmetic side, if you give them 0.5 millimeters to 1, I like to do way less than 1. I try to shoot for 0.5 to 1. They can work and create a beautiful restoration. They can create a layered ease max. A lot of labs like to do feldspathic, but that range gives them the room. So what I do is, with this mock-up, I take a reduction burr and I start prepping. Okay, I use a 0.3 and 0.5 burr, which I'll show you, because I want to create a conservative prep. Where this technique started, whether it's a researcher, a clinician, Galip Gurel, and he's the one who's the most well-known for this technique. He wrote an article in 2003 looking at creating, very conservative, minimally invasive, veneer and anterior preps. Now, the key is when you're doing veneers, you want that bond to be on enamel. If you have a veneer restoration that's bonded to enamel, it's incredibly strong. Okay, that bond is incredibly strong, and that veneer restoration can be as strong or even stronger than your crown restorations. But once you start prepping into dentin, now the bond is weaker. So what is the thickness of enamel? This is very important to know. Okay, so there was an article in 2019 where they discussed the thicknesses of enamel, and here it is for centrals. It's 0.4 millimeters at the gingiva, it's 0.9 mid-facial, and it's 1 at the incisal plane. Okay, now why this is important, you want to be very conservative, especially in that gingival plane when you're prepping that veneer, and you have a little bit more freedom as you're going towards incisal. For laterals, it's actually, the numbers are a little bit less. It's 0.3, 0.8, 0.9. For canines, it's about 0.3, 0.8, and 1. Okay. These burrs, I like to use the same dimension burrs. I use a 0.3 millimeter and 0.5 millimeters. You can get these burrs with different wheel sizes, like a 0.3, 0.5, 0.7, all on that one burr. But this is what I like to use. And I like to cut it in different planes. So my 0.3 I'll use on that gingival plane, and I use the 0.5 millimeter one on the incisal plane. So now we've got the prep. Again, everything on this is veneer preps, except for that replacing that 2-1 crown. And this is a labial reduction matrix. Okay, so what this does is, again, it's off the wax up, and on the teeth that we're not prepping, it wraps over the occlusal. So we got a nice stable support for this. Okay, and I also have it seated on the palate too. So so it's going to be locked in, and be stable. And then on the labial side, what we teach at the academy is we cut 3 slits, and now we can pull these slits off of the teeth and we can see where we're prepping. And then I like to take a photo and have a look and see where I am. And so most off, we have room pretty much everywhere. Off the 2-3, tooth number 11, and 2-4, tooth number 12, I can see I'm just slightly under reduced on those mesial labial line angles. So very simple, I just go back in and just re-prep and polish those. Now, this is one of the things that was very frustrating, when you go through the AACD, they have an accreditation process. And just with my cosmetic cases, one of the things that I found very frustrating was sometimes the gingiva didn't respond the way I was hoping it to. I would see, inflammation along crown margins, or, gums slightly receding after the veneers or crowns are placed. So one of the big things where I focus, with my CE and research is looking at this periodontal restorative interface. This is what, I'd like to focus on, because I want to make sure that the gums look great. One of the big teachers on this is an excellent teacher, is John Coyce. John Coyce in 1994 looked at an article where he came up with this classification looking at crest levels. Okay, so what he was doing is when you're bone sounding on the midfacial and interproximal, he was developing a classification system for crests. So low crest, okay, so if you're doing that bone sounding, it is the bone is greater than 3 millimeters away from that midfacial free gingival margin, and greater than 4 millimeters away on the interproximal. This is about 13% of patients from that study, and these patients are at more of a risk of recession. Okay, so if you placing cords with any sort of trauma, or you're placing your margin subgingivally, and there's any trauma that gingiva, you can get the recession happening. Normal crest, the one is exactly at 3 millimeters and exactly at 4 millimeters. And that's about 85% of patients, which is a lot. And then high crest, which is your lowest category, is about 2% of patients, is when it's less than 3 millimeters and less than 4 millimeters. So normal crest is your most stable. So even if there's any insult to the gingiva when we're cracking that core, again, from our prep, it responds more favorably. High crest, if you're placing your margins subgingivally, which was I like to do, I like them to be about 0.5 millimeters subgingivally just to hide them. You're at risk with the high crest patient to violate that biologic width, which we all know, and it can cause inflammation happening. So we did bone sanding for this patient. This is a photo you can see here, and you can see from this, it's 3 millimeters, so we know she's a normal crest patient. So now what I like to do, again, this was Trevor Langchild's an amazing technician, and we work on these cases together. And look in these cases, what I like to do is take a step back once I've prepped and polished my preps, is take a step back and look at the margins. Look at them from the central shot and my lateral shots. And what I'm looking for, basically I'm looking to see, am I hiding those margins? Are those margins being hid? Because something that can throw off the aesthetic look of your cosmetic case is if you're doing a conservative veneer prep, but you can see tooth structure. Okay, so you haven't hidden that tooth structure. Say you haven't put that interproximal margin, lingual enough to hide it. So we were happy with where the margins were with this case. So now we are doing our record, our centric relation record. Like I told you with the patient, when we did our records, we like to use a Leaf Gage. We realigned that with that dreaded green compound wax that nobody really likes to use, and then we use that Delar wax. Or when I'm getting into a prep, okay, the Leaf Gage doesn't fit as well. So what I like to do, I like to use my Leaf Gage. Okay, Leaf Gage is a great way to position somebody in centric relation. The only contraindication is if somebody has a deep bite, your class 2 div 2 patients, like a deep 90%, 100% overbite, because those patients, if you use a Leaf Gage, the risk is you can actually distalize the condyle. So instead of being in CR, you can actually be distal to that position. Okay, but she's not that. So what I do, what labs love is if you can give them a tripod of a bite. Okay, so what I do is I use that Leaf Gage, I have them slide forward and back and lightly squeeze, and then I confirm their centric relation by load testing and making sure there's no tension or tenderness in their joints. And then I squirt blue mousse. I mean, you can use whatever bite registration material you like. I used to use one from Great Lakes, this pink registration material, which is also fantastic. And I squirt on the back teeth, okay? And then we've got a record there. Then I have her open, make sure she can close into those back registrations and that she's secure on both sides. Then I have her open, take the Leaf Gage out, and I squirt blue mousse on the anterior. So now the lab has a tripod of a bite. So now this is her, we're checking her 48, we check our patients 2 to 3 days, sometimes even longer, after we've provisionalized and prepped to check those temporaries, making sure that she's happy with the aesthetics of them, phonetically, her speech is good, there's no issues there, and functionally that everything's stable. Okay, when we make our temporaries, again, I showed you that putty matrix that we use. We like to create a polychromatic look. So what I like to do is I use integrity. I use A2 at the gingival part of it. I squirt that in, And then I use B1 on the top to create, this polychromatic look. So we take these photos once they're happy and we have the approved provisionals, and we take these photos, we send them to the lab. You can see from this tip down smile, we've built those canines and the laterals forward. She had left, and I could see that the canine and the lateral 1-3 and 1-2 are slightly forward of that vermilion border. So we had the lab tuck that back. And again, I love this shot. This is a shot where you actually sit behind the patient and you take this photo. So it's like a reverse tip down smile. And it's a great way to see how your temporaries line up and your final restorations relative to the lower lip. One key tip I want to mention to you too, again, in terms of mastering the periodontal restorative interface and communicating to the lab. Okay, so one of the things that could kill your cosmetic case is black triangles. Okay, and one of my biggest idols, I was fortunate to take a course with him in IDEA, is Dennis Tarnow. And him and his team in New York, they do so much research. I mean, they're still continuing to do research, like 30 years of immense game-changing research, okay? So on implants, surgery, and what he was known for, even though he's done so much research on implants, he's known for his research with his papillas, okay? And what he found in the study that he did in 1992 is that if you set that contact point to be 5 millimeters or less from that interproximal bone, you're gonna get papilla fill. Anything beyond that, 6 millimeters, 7 millimeters, now you're risking of getting a black triangle and the papilla not filling that area, which your patients will always complain about, even ones with low aesthetic demands. So here's a tip: when you're taking, whether you're taking a PVS impression or your scan, we use the 3Shape for our impression of our preps. The lab doesn't know where the bone is. All they know is where that interproximal margins are. So what you do is you do your bone sounding, find out where the bone is relative to the interproximal margin. So let's say the bone is let's say between the 2-1 here, okay, the bone is 2 millimeters away from that interproximal margin. Well, then I tell the lab, please set the contact point no more than 3 millimeters away from that interproximal margin. That way it's gonna be less than 5 millimeters, and then hopefully I'll get that papilla fill. And I do that for every single one, from the 1-4 all the way to 2-4 for each one. So 1-4 mesial, 1-3 distal, 1-3 mesial, 1-2 distal, all the way across. Okay, because I want to make sure that the papilla heals well. So now we're into the final stages, the stable glass, creating the restorations that hopefully are going to be predictable and last. So what this is very important, and what I send to the lab too is once we have the provisionals approved, we scan that. Okay, the patient's been equilibrated, so I don't need to do a bite record. Okay, so I've scanned the provisional model. I have the lab mounted to the lower model. Okay, and why I want the lab to have this model is because I want them to use this for where they're going to set those incisal edges. Okay, both vertically and horizontally, because I've already established that with the patient. The lab's going to add all the details, like Jeff was talking about. His lecture was fantastic last week. But those subtle nuances, your translucencies, that polychromatic look, the primary, secondary anatomy. The lab's going to do all those details. But what I want is them to follow my provisional. So what this is, that index, okay, is off the provisional. It's seated against the lower model. And then what I do is I take all the porcelain restorations and I fit them in and make sure that this follows the index of this approved provisional model. So I know the lab is doing what I want them to do. So now we're doing the try-in stage. I have so many mentors through the Dawson Academy, John Cranham, Glenn DuPont, Drew Cobb. And my biggest one from the cosmetic side is Scott Finley. Scott Finley is one of our teachers there, and he's also a teacher at the AACD. He's one of, I think there's only 70 fellow AACD members, which he is one. And he's a big proponent of Ivoclar products. I believe we have Rachel McKay is going to be speaking about Ivoclar products later this month, which would be great to see. I love Ivoclar products. I love using Varial Link Cement for my interior cases. And so what we do, they have different shades. They have light, neutral, and warm. It used to be more complicated than that. Now they have a light plus and warm plus. I didn't know that. But I have the light, warm, and neutral. Okay, and they have the corresponding try-in paste. I used to believe that cement doesn't matter in terms of the final look, but it does matter. And I've learned that the hard way. So, always use a try-in paste before you cement these cases. I usually use a light for bonding my cases. Sometimes I use neutral. I rarely, if ever, use the warm. Okay, so we're trying it in. We're happy with the shade. So we cement it. Okay, we bond everything in. Ivoclar has a whole series of things. The mono bond is for the restorations. Ivoclean to clean the restorations, and then your etch bond and the Verilink cement. And then these are the shots. Again, she was ecstatic with the result. We were very happy with it. You know, you can see the 5s there are tucked in. You know, maybe in the future she'll do veneers on those 5s. And this is the other shot here on the side. Here's the key. The key, again, it's not just aesthetic treatment planning or aesthetic treatment, it's functional aesthetics. So what we need to do is establish that occlusion. And in order to make sure these cases last, this is what I need to do. And this is what I was talking about earlier in this webinar, is establishing a bite where it's CR equals MI, the anterior guidance is harmony with envelope of function, and then we have non-interfering posterior teeth. So what I've done is I've marked the teeth. Blue is for centric stops, and red is for excursion. So you can see we've cleared the interferences on posterior teeth, and the guidance is only off the anteriors. Now again, because she didn't restore those lower anterior teeth, there's no centric stops from 1-2 to 2-2, from 7 to 10. But again, we're able to get guidance, okay? Which is, again, key for me for treatment planning these cases. One tip, I love to use a small football carbide burr. Everybody has different types of burrs they like to use. I love using this burr for my equilibration. This is what because I can get into those, adjust those inclines on posterior teeth and the anterior teeth too. So that's my burr of choice. In terms of polishing, your intraoral porcelain polishing burrs, not your zirconia polishing burrs, but the ones that you use for Emax restorations, you can use that on enamel too, or you can use your brownie points to polish enamel. Then obviously everybody has composite burrs that they like to polish with. You can use that too if you're equilibrating on composite restorations. One thing, whether you decide to equilibrate or not, one thing I would highly recommend, especially for people on this who are interested in implant dentistry or who do a lot of implant dentistry, I mean, which are many people on this webinar, is the use of a TEC scan. Okay, a TEC scan is a digital recording of a patient's bite. Okay, and it's a great way to make sure that your marks, is actually what's happening. Because sometimes marks don't tell the whole story. It's when you mark their teeth, it's a snapshot of their bite. Whereas the TEC scan it's looking at the bite, is a dynamic look at the bite. You're looking at over time range, a very short time range based on when that patient's contacting. So here you can see I like to do my TEC scan recordings. I do like to do 3. The excursive ones, left, right, actually a protrusive one too, and then this is her centric bite to make sure the forces are balanced. This is her left this is her left excursion off of tooth, and you can see here with her grinding to her left, she's only contacting on the canine. Great, no posterior interferences. This is the right side, grinding to right side, only contact on only contact on number 1-3 here. And again, no posterior interferences. And this is her centric stop. So her biting down, you can see the forces we were happy with how well we were able to balance it. You can see one key thing, if you look on the side, you can see underneath this, the arch, there's a left and there's a right. And underneath that, it tells you the forces, okay? So it tells you percentage of force. So in this case, it's about almost 53% on the left, almost 47, 48% on the right. Getting 50-50 perfectly balanced forces is very difficult. I've only done it a couple of times. But if we can be in the range from 45 to 55%, this is something that can work very well. And so we were very happy with this. So now you're going to see here, you're going to see now, this is her actually biting into it. Okay, so you can see how the forces all come up on this. And it's over, it's like a half a second to a second. It's not much time. You can see how the forces come in. Why I was recommending TEC scan for people who are doing implant dentistry. We know that teeth have an axial displacement. Okay, it's about 25 to 100 micrometers for teeth, but implants, we know they're like rocks. Okay, there's barely any axial displacement. It's about 4 micrometers. So why that's important is if you have a TEC scan and you're restoring implant restoration, say couple of teeth have implants, you want those implant restorations to be the last ones to come into occlusion and the first ones to leave. to account for that axial displacement that happens with teeth. Because if you don't account for that, then they're going to be banging into those implant restorations, which again, over time, the force on those implant restorations can cause failure. So now this is just a summary. Now, what I've been showing you is finding flow in terms of, how we're going to establish these cases. So this is her before. Again, this is her after. And again, she was very happy with it. We were very happy with it. But the key again was we wanted to establish that occlusion and make sure that these restorations last. So when we're talking about finding flow, okay, it starts within our mind, okay, doing a detailed examination, looking at everything like we do, but also really involving that functional component, and then taking the photos. Whatever photos you take, I know DSD, for example, they have a series of photos. A lot of other academies have photos they take too. AACD, for example, they recommend 12. Dawson, we like to take 21 so we can really plan the case. And then from that two-dimensional planning, we get into our 3D. So doing the treatment planning wax up, and then having the lab finish the wax up. And then from there, we go into our provisional. So after we've done our prep, we've done our surgery, and we're doing our prep, we work it out on plastic. Make sure the patient's happy with it, and that functionally it's working, phonetics is good, and the aesthetics obviously are great. And then from there, we go into glass, the final restorations. The goal with this, again, is, why I'm teaching this to you guys, sharing this with you, is I want predictability in my cases. I want the least amount of problems, and I want the restorations to last and create a smooth flow from start to finish. But even if you follow, a flow like this, sometimes, despite your best efforts, sometimes the road isn't a smooth road. It's an incredibly windy road. Things that you couldn't account for happen and creates these curves that you have to deal with. This is a case, where I'll show you. This is one of the cases I'm most proud of. It was an article. It was a case I wrote an article about, and it was about dealing with a canted smile. She was referred to me again by the same orthodontist. He did a great job with this case. She was actually missing her 1-3, number 6, so the premolar was brought into that position. And but again, it was a slight canted smile. She had an anterior open bite. So this is her after we finished the case, and I want to tell you that just went from A to B, A to B, and it was nice and smooth. And we were happy with this aesthetics. She was thrilled with the aesthetics, but it wasn't an easy road because she had very high aesthetic demands, and high aesthetic demands can create for a very arduous journey. So again, did the 2D planning, okay, and then we went to the wax up. This wax up was changed 3 times. And I'm very specific with my planning and my lab scripts, but because she wanted to tweak things, it was changed 3 times. And then we worked out. When I do my full mouth cases, I like to, prep provisionalize the lower, prep provisionalize the uppers, and then I do the permanent restorations on the lower first and then the uppers. That's my sequence. Everybody has a different sequence. So anyways, this is her lowers. We had to adjust her provisionals in 2 appointments, adjust them twice. And we had to try in the lower portion restorations twice before they went in permanently. These are uppers, upper provisionals, lowers are in. We had to tweak our upper provisionals 3 times, and we tried in those portion restorations 3 times before they were cemented. And then I actually had to bring Trevor into the office to help me do some minor adjustments, these micro aesthetics before she was happy with the case. So it was an arduous journey, but again, the key was functionally, I knew, even though it took a while to get there, that if I set up this case well, that, she's going to have peaceful neuromusculature, peaceful functional harmony. So here she has an anterior open bite on the left side. And then again, in the final restorations, we were able to do the exact same occlusal scheme that I discussed, only we were using the premolar as a canine. So 1-4, number 5, we're using that for canine guidance. The key again is I wanted to create this, this occlusion, because then she can have peace of mind. Okay, so this is her 5 years later. She's a selfie queen. She loves. This is a photo she shared with me. She's really one of my favorite patients. This is her with her. Her daughter and her daughter and family, and this is her again here. And she's thrilled. What she wanted her upper teeth to look like her daughter's smile. And now she has a peace of mind. But the key is I want peace of mind. I want peace of mind that my restoration is going to last, and that I can do what's the most important thing, is enjoy my blue time with my family. So with this, I'll leave with a quote. To begin with the end in mind means to start with the understanding your destination. That's from Stephen Covey, who's the author of the 7 Habits of Highly Effective People. These are links. The Dawson Academy, again, is where you can do a lot of this training, which I would highly recommend. The AACD is a wonderful resource. Their meetings are great. For Canadian dentists, is the Canadian Academy of Restorative Dentists and Prosthodontists. It's CARD P. It's a wonderful meeting for you guys to consider a group to join. We meet once a year in Halifax, Vancouver, Montreal, or Toronto. This year, sadly, it was supposed to be in September. It's being canceled because of COVID. I'm part of a podcast with John Cranham, the director of the Dawson Academy, and David Rice, who created a website, an organization called Ignite DDS, IGNITE DDS. It's a wonderful platform for young dentists or any dentist, and gives you really great tips on, growing as a dentist. And lastly, and just as important, the Dentistry Academy. I mean, these guys are wonderful. I mean, Hisham, Mark, John, Mayan, and Jeff. I mean, these are wonderful guys, and their courses they're going to teach, I know, are just going to be amazing. And with that, I want to thank you.
Thank you so much for that, Pio. That was absolutely incredible. It all went well and nice and smooth this time. So thank you for that.
I'm just going to plug my power into my cord. Just one sec.
No problem. All righty. Thank you guys for joining us. We're going to go ahead and pass on, while we're waiting for Pio, we're going to pass the mic to Azim to talk about some housekeeping items.
Yeah, thanks, Hisham. Yeah, that was great, Pio. I don't know if he's there somewhere.
Thank you.
Good job, buddy. Nailed it. So just some housekeeping items. So first off, obviously, just make sure you type your name and email address, and that's just for CE verification. Make sure you visit the dtacademy.ca, because there's obviously more upcoming webinars that are coming up this week. So we want to make sure that you register for those in advance so you don't have any issues logging in. The video will actually be uploaded to the Dentistry Academy YouTube page. So just make sure you subscribe to that. And then, of course, there's also an Instagram and LinkedIn page, and that where you get updates on, when the courses are coming up, and a reminder, a gentle reminder, as we all need for that. Tuesday, which is tomorrow, May 12th at 11, we're going to have Dr. Ben Mueller, who'll talk about balancing treatment needs with patient individuality. And then subsequent to that, we'll have Mr. Christian Hall, who will be talking to us about implant treatment planning using CBCT. So just make sure you register at the DT Academy site, and then the password, as always, is track20, and that's all capital letters. So I will pass it over to Katie for questions and answers.
Hi, Dr. Modi. That was an excellent
how are you?
presentation.
Thank you.
We have a few questions here, so bear with me. So this is from Anonymous. How much do you open the patient while taking your CR record?
Great question. So that's a great question. It's so long as they're not moving on a rotation, you're safe. Now, I don't open much, so it's a great point. So let's say with the example with the leaf gauge. Okay, so a leaf gauge, what I find is it's a great way for people if you're starting with CR records. It's very easy to work with. I use about 40, 45 leaves. So the exact millimeters, maybe like I'm opening up to 5 millimeters max in terms of the record. The Delar wax that I use for those records, again, the thickness is not much. It's maybe, again, I think it's maybe 3-4 millimeters. So it's a great question. I think, as long as you're, 5 millimeters or less, you should be fine. And if you're losing a leaf gauge, I would say what I was taught from one of my mentors in Canada, Emo Rajsak, an amazing dentist, is to, he recommended us using about 45 leaves in that leaf gauge.
Okay. And then this one is a long one from Andre. So he says the burrs at gingival, the burrs at the gingiva cut 0.3 millimeters, and that is what people aim for. But veneers may need to be redone eventually. Is the enamel compromised, especially at the gingival area when you are doing the veneer, the redo of the veneer? And assuming it is your case to do your prep a little less than 0.3 millimeters with this in mind?
Great question. So, a lot of people, there's a lot of people out there who are doing no prep veneers. Okay, so so I know a couple of the big people with the AACD. I believe Dennis Wells is one of them, and they do a lot of no prep veneers. Now, no prep veneers where then you're not taking any enamel away. I want to make sure that I can hide my margins. So in terms of answer his question, as far as he's right. Like I'm incredibly cautious in that gingival. Okay, so again, that's why I use that 0.3 burr, and I even try to be less than that in the gingiva. But at least, I mean, that's the smallest depth burr that I have. And then I'm very, very low RPM. I use electronic, hand pieces, so I use a very low RPM to adjust that. If you have to redo it, okay. So say if you have to redo a veneer, which it definitely can happen. He's right. If you take off that veneer and prep it, you invariably are going to take away some enamel. Now, with a veneer, the goal is that majority, if not all of that veneer is bonded to enamel. Now, if some of it's bonded to dentin, I'm okay with that. Obviously, I'm trying to avoid that, but I don't think to answer his question, if you are into dentin in that gingival part, do I think that you have to switch now to a partial, like an onlay, a veneer hybrid, or a crown prep? I don't think so. I think as long as the majority of your restorations on enamel, I believe you can still be very conservative with that veneer prep. As far as no prep cases, I haven't done one yet because, again, I want to be able to hide my margins, and I don't want my veneers to be too bulky. And so that's why I haven't done a no prep case. But I know there's a lot of clinicians out there who are doing that.
Okay. And then he also adds, if the patient has recession in the front, how does that affect your treatment planning as well?
Great question. So that slide where I was looking at the gingival symmetry, and that slide, the smile design, the numbers, if there's recession is a great point. What I do is then I'm adding gingiva. So I'm looking to grafting, whether, like, again, I like to do my own periodontal surgeries. But if not, I'm referring to a periodontist. And again, that'll be part of it. It's a great question. So gingival symmetry for me, even if a patient doesn't have hypermobile lips or not showing their gingiva, I'm still trying to make it perfect. And so if it involves grafting, that's what it's going to be. If it involves grafting or aesthetic crown lengthening or both, that's what it's going to be. And that's where we're going to start it again. Surgery for me is a rate limiting step, and that's where we would start it.
Okay. And then again from Andre, what factors or flow do you consider when deciding whether to do ortho and pros, or just pros for these cases?
Man, these are great questions. These are great questions. So that's a great question. So ortho, I have a lot of cases where I will refer to orthodontists. So what I like to do, because majority of orthodontists don't work with articulators. I mean, that's just their patient flow doesn't suit that. They're seeing 80 to 120 patients in a day. It doesn't make sense. So I still bring them in, do the exact same exam and their records, okay? But I'm not doing a diagnostic wax up. And then I'll meet with my friend who's orthodontist, and we'll go over the case, where I want the teeth to be, where the position, everything. So the flow then would be, ortho is even though more of a rate limiting step. So it's ortho, okay? And then when he feels, orthodontist feels that the case is going to be completed, like 6 months out to 3 months out, I want to bring that patient back in and make sure the occlusion's where I want it. Okay, that they're establishing those teeth with minimal to no slide from centric relation to maximum intercuspation, and that he's building in that guidance. Okay, so that because a lot of times I see orthodontic treatment. I mean, orthodontists they do incredible work. Sometimes I see there's very minimal overbite, and the lower anterior teeth aren't socked in to those upper teeth. So again, so as far as that flow, patient comes back to me 6 months to 3 months out, I make sure he's on the right track. I send him a letter, let him know we're good to go. He finishes the case. Then again, the same flow as before. If it's surgery, and then we go into prep.
Okay. This question is from Mohammed, and he asked, where were the incisals of the lingual margins of these veneers that you showed us in the case?
So great question. What I like for my, when I do my veneer preps, okay, everybody has different design preps for the veneer. My incisal of a veneer prep is flat. Okay, some people like to wrap around, create a lingual chamfer on those teeth. I don't. Okay, so I keep it's a flat reduction. Now here's the thing: the beauty is if you're lengthening teeth, okay, if you're lengthening teeth, what I want is about 1 millimeter reduction. That's what my lab wants, and that's, you know, that's what I'm shooting for. Okay, so if you're lengthening teeth by 1 millimeter, here's great news. You barely have to do anything to that incisal edge. You don't have to do anything to it. I mean, her case, her laterals and the canines, I barely had to touch them. Okay, it was very minimal. And again, the key is having reduction matrices so you know how much you have to reduce. But I'm flat on that incisal edge, so it's actually a butt margin. Okay, so it's actually the veneer sitting on as a butt margin up against the tooth. Here's a key point too, wherever your centric stop is. So for her, again, those centric, she didn't have centric stops of those the incisors, but mark your patient, have them bite down first, know where the centric stops is on the anterior teeth, and you want to keep that margin away. I mean, you don't want that, you know, that margin between the porcelain and the tooth to be right at where that centric stop is. That's just a force you don't want. You want that margin to be away from there. But I'm a porcelain butt margin. It's a flat incisal reduction, and I just want 1 millimeter clearance. That's it.
Okay. The next question is from Nadia. She says, thank you, Dr. Modi, for your time and for coming again. And then she asked, for this case, at what stage do you prep the Lucy jig or use the leaf gauge? And then their second question was, for provisionals, what cement do you recommend?
Great. Oh, I love these questions. They're great. So Lucy jig, again, I like to use the Lucy jig in the initial, my initial part of my records. And again, it's a wonderful technique for you guys who want to get these bite registrations because it's a deprogrammer. But the problem with the Lucy jig is when you prep teeth, the fit is not going to be that great anymore. So then a leaf gauge is where I use for when I prep the case. The second part of her question, I'm sorry, can you say the second part of her question?
The second part was for the provisionals, what cement would you recommend?
So again, I do a lock on provisional. Okay, so I because veneer, now some people know I've done bonded versus lock on. Okay, so bonded is you use a spot etch, you do an spot etch on the tooth, add bond, and then you actually do the provisional. You can take it out, and then you can use one of your temporary cements, like my go-to temporary cement is a Tempon Clear. But I find a lock on provisional, again, Scott Finley taught me this, and the Academy teaches this. I find that works very well. It's less work on your end because here's the problem with veneer temporaries. I mean, they're very thin. Okay, it's very fragile, very thin. The more you're taking them off, reseating them, and dismantling them, the more likely there's a risk that it could break or snap, especially if you're doing a no prep case. So I like to lock on my provisionals. That works very well for me. That being said, even if you worked out the occlusion perfectly, sometimes these cases, they can come back a week or so. There could be a crack, especially in the premolars. Okay, so, but again, whether you cement it or not, I think that's unavoidable. So keep it easy for yourself. I would do a lock on and then just trim the excess. Make sure you've trimmed all the excess so you're not impinging on the gingiva, and that just makes it simpler for you.
Okay, the next question is from Mark. He has 2 questions, I believe. So your mock-up transfer, on your mock-up transfer, do you use a pure silicone key with vesicular transfer, or in some cases, do you use a McLaurin style matrix clear style or for flowable?
Okay, so he's saying, I'm sorry, can you say that again? I just want to
Sorry,
make sure.
so your mock-up transfer, do you use a pure silicone key with vesicular transfer, or in some cases, do you use a McLaurin style matrix clear style for flowable?
I mean, for my mock-up, I'm using, very simply, I'm just using the exact same stent I'm going to use for my provisional. So that putty stent that you saw. Now I've done different ways. I've done it with an Essex style. Okay, so we do an Essex off the dianosyl wax up and put that in there. But what I found with when I'm using these clear trays for that mock-up, sometimes getting that Essex off can be a problem. Sometimes getting that Essex off can cause damage to it. So I find that putty matrix, that one where with the blue putty with that orange relined PVS, that works great. And so I'm just doing it the exact same way I'm doing my provisional, and then I seat it down. And the key thing with those matrices, you got to make sure that the lab is making sure it's seating on. So say for example, it's a full mouth rehabilitation, or all the teeth are waxed up. So that means you need to make sure that that putty is engaging some soft tissue. So you have some landmarks for it to see. Because if not, you know, you don't know where to fit this properly. With her case, because we weren't, you know, prepping second molar back, you know, those teeth were providing the stable soft for that. But again, I just use that putty matrix for that.
Okay, and then Mark again asks, would you consider a chairside printer for future mock-up protocols and prep through guides?
That's a great question. Great question. Well, that's one of the things yes. To answer this question, yes. I mean, so the Academy, I feel DOS Academy is really on the forefront with digital, and we're really pushing it. And we have somebody now as part of the Academy, Lee Culp, who's really one of the biggest lab techs. I mean, he's an amazing lab tech, but he's really big on this digital side. So that is my goal. I mean, I have the 3Shape is to eventually start printing these mock-ups. So I'm planning, you know, when this COVID shutdown is done, to go down with one of the other faculty members to Sealy to do these small design off of the 3Shape and using the software. And then, yeah, exactly. Printing off the mock-up, printing off provisionals. It's a great question. Answer is yes. I'm not doing that right now, but that's my goal, 100%.
And then the last question I have here is from Mark as well. And he asked, do you use surface prep with intraoral sandblasting, such as Prep Start or OccluSal, to increase veneer bond strength?
That's a great question. I'm going to, I do not, but yes, I would definitely recommend that. There was one of the webinars we had with the Academy, one of our faculty in Europe, and she was showing that, okay, that sandblasting just to improve that adhesion. And her work was beautiful. It was looking at onlays, inlays. So answer is yes, it's a great idea to do that sandblasting before you do your etching and your bonding. So I'm in agreement with that. Am I doing that right now? No, but that I am planning on implementing that, especially when I saw her webinar. It just, if I can improve my adhesion, 100%.
Okay, and that's all the questions that I have. So
great.
Thank you.
No
Thank
problem.
you so much for that, Katie. You did a great job. And thank you, Pio. That was absolutely incredible. So that wraps things up for us today. I would like to thank all our co-hosts, Dr. Azim Sheikh and Ziad Hamad, and of course, Katie Dhaliwal for the question and answer. I'd also like to thank our speakers as well, Dr. John Mansour and Dr. Pio Modi, for such amazing presentations. So thank you guys so much. Very informative, and we appreciate your time. We look forward to having everybody join us tomorrow at 11 a.m. Thank you so much, guys, and enjoy the rest of your day.
Thanks, guys. Thanks,
guys. Have a good day. Thanks.